The topic is bypass versus stenting in long femoropopliteal lesions. This is our own data from Mount Sinai, from a study conducted in Mount Sinai. I have no potential conflicts of interest to declare. So, revascularization in PAD patients with CLI is fundamental for limb salvage and reduction of mortality, and it's appropriate for patients with intermittent claudication after exhaustion of conservative approach. In the past, bypass surgery with autologous vein graft implantation used to be considered the gold standard for the treatment of PAD in the infrainguinal segment. However, early complications like bleeding, hematoma, infections, prolonged hospital stay are considered a limitation of bypass surgery as a first approach for all patients in this, with PAD in this arterial segment. On the other side, endovascular therapy offers a less invasive approach, is more convenient for the patient, and is associated with lower rate of early complications. Several observational studies and randomized clinical trials have been conducted to compare the outcomes in this patient population. The earliest study, as we all know, was the BASIL trial. 452 patients with severe limb ischemia, 75% had tissue loss. Endovascular therapy was performed only with POBA as compared to the gold standard autologous vein in the bypass surgery arm. The trial was conducted for 2 years and extended up to 5 years, and primary outcome was a solid endpoint, which is amputation-free survival. And after 2 years, the curves were comparable, but after extending the follow-up after 2 years, bypass surgery was used to have favorable outcomes. So this is, would have stenting in endovascular therapy have changed the outcomes of the BASIL trial? Well, we will never know that, but there are some smaller studies, also randomized, who used endovascular therapy as compared to bypass surgery and analyzed outcomes. However, if you see those studies, they are mostly smaller size and were targeted to investigate primary patency or other surrogate endpoints rather than amputation-free survival or major adverse limb events. Therefore, we thought to perform a literature research and identified 6 randomized clinical trials using scaffolds in endovascular therapy as compared to bypass surgery with prosthetic or vein material. The primary endpoint which we selected was major adverse limb events, a composite of all-cause death, major amputation, or reintervention of the target limb at 2 years. The secondary endpoints were all individual components of the primary endpoint, plus amputation-free survival and primary patency at 2 years. The safety endpoint was a composite of all-cause deaths, any bleeding or infections within 30 days after the intervention or the surgery. And this is how the study was constructed. We identified the 6 trials. We contacted all PIs of all the trials and had a Zoom meeting with them. 5 principal investigators agreed to pool the data, and this is the table including all the studies which were used in this patient-level meta-analysis. And here are the first results. The pooling of the data resulted in a total of 639 patients, comparing stenting with surgery, and as you can see here, the baseline clinical characteristics were fairly comparable between both groups. The only lesion type, occlusive, was significantly higher in the bypass patient population. Also, lesion length and task 2D lesions were comparable between both groups. And here is the primary endpoint after 2 years. Major adverse limb events were comparable and were not significant in the crude analysis, as well as after adjustment for baseline clinical characteristics, which were different. And so was also amputation-free survival after 2 years was comparable in the crude analysis as well as after adjustment. This table shows you the individual components of the primary endpoint, no differences at all. Only primary patency was in favor of bypass surgery over endovascular therapy and remained significant after adjustment for differences in baseline clinical characteristics. Here in the bottom, you see that the mean duration of hospitalization was significantly lower in patients who went for stenting as compared to bypass surgery. And here are the early safety endpoints, 30-day composite of all-cause death and bleeding or infections. So all-cause death was comparable. Bleeding and infections were in favor of endovascular therapy with stenting, and so was also the composite endpoint. There are certain limitations which we have to acknowledge for this patient-level pooled analysis. All the trials were conducted over a period of 20 years. During those 20 years, many devices, especially with the stent technologies, have improved and changed in their iteration. The inclusion and exclusion criteria of the patients enrolled in the studies were fairly different, and so were also the endpoint definitions. Therefore, it was very hard for us to calculate the safety endpoints at 30 days. Another important notion is that patients enrolled in these studies were all deemed as appropriate for both type of procedures, bypass or surgery, meaning that this analysis does not apply to all patients who present to us, because some patients might have better outcomes with endovascular or surgical, as we know from clinical predictors. And finally, guideline-directed medical therapy is completely underappreciated in this analysis and has changed dramatically over the last 20 years. So in conclusion, we can say from this patient-level pooled analysis that in patients with symptomatic PAD involving the femoropopliteal segment, endovascular therapy with stent implantation compared with bypass surgery was associated with similar 2-year rates of major adverse limb events and amputation-free survival, but lower rates of early complications and shorter lengths of hospitalization. This pooled analysis of individual patient-level data supports the efficacy and safety of endovascular therapy with stenting as an alternative for patients with femoropopliteal artery disease, as an alternative to bypass surgery. Thank you very much.